Now it is. Thank you. Okay, well, thank you.
Thank you, Harlene.
Okay, so I'm just delighted to be here. And tell me which class this is.
Remember what class
you remember what class you're in?
It's Theories of Marriage and Family.
Theories of Marriage and Family, okay.
And orientation. Some people from the orientation to the profession.
Okay.
And professional ethics.
Okay, great. Anyone else from a different class that hasn't been mentioned so far? Okay, so it's summer school, right? Always a challenge to spend your summer in school and on campus. So how many weeks are your classes? 6 weeks or? 10 weeks, okay. You can tell how long it's been since I've been in class. Okay, let me ask you the time frame.
Well, we're here till 8:30. So
You're here till 8:30, okay.
Stay as long as you want.
Okay, so we have some flexibility in time. Okay, so what I'd like for you to do is I have a lot of things that I can share with you in terms of my ideas, which I call my biases and prejudices, things I'm biased and prejudiced toward, and a lot of experiences that I can draw from. But I need your help in terms of what to select that would be most relevant to each of you. So if you would just turn to your neighbor in twos or threes, however you can do it in this room, and just share with each other, what do you hope you will take from our time together? What are your expectations? Particular questions, interests, topics? Okay? Let's just take 4 or 5 minutes to do that. Okay, shall we come back together and let me have a sampling of some of the things that you were sharing and talking about in terms of your expectations or your hopes for our time together.
Collaborative language. Mm-hmm. So I'd like to know a lot more about that and also how it's different or alike from or to narrative.
Okay. I'm just going to make some notes to help my memory. So this will be my translation of your language into mine, okay? Okay, great. Thank you for starting us off. Someone else? Okay, great. Let's see, I think she was first and then you. Okay.
I was just wondering what some of the stumbling blocks are that you encounter.
Okay. 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 Okay, who's next? Do I get to select a volunteer? Someone from this part of the room? Yes, thank you. Oh, advice for success. Okay. These are all great. Yes.
I'll speak for some of my
Okay.
students. They're very new, and I think
Right.
they're shy. I think they're wondering what is this marriage and family about? What would
Okay.
be in it for them to go that route?
Okay, okay. So I'll just put YMFT. Route. Thanks. Okay. Anyone else on this part of the room right here? Well, this will get us started, and you can. Oh, Adriana.
I was just going to are not that familiar with postmodern practices, about how the shift started happening and what you started seeing when you were beginning as a.
Okay, okay. Okay, we can add to this as we go along, and if you want to make a comment or ask a question, just catch my attention. Okay? So, what should I know about what you've read in your course that has anything to do with postmodern social construction direction in psychotherapy in general and family therapy in particular, or in terms of a collaborative approach? I'm not going to quiz you on it. You haven't gotten that far. Okay, okay. Next week. Okay. Okay.
And no one read ahead, of course.
Well, it's the summertime, of course. I understand. Okay, so I'll just back up and do a really quick kind of review of my thoughts about the trajectory of marriage and family therapy. Okay, so marriage and family therapy first became, if you want to say, an interest, a research area, practice beginning in the 1950s. And in the late 1950s, there was a group in Galveston at the University of Texas Medical Branch in the psychiatry department who developed a way of working with families called multiple impact therapy, or MIT for short. So the ideas that I talk about, that I'm biased toward, and that I'll be sharing with you have a long, long history with its roots way back in those days. And what was happening is that at that time, it was a very hierarchical, you want to say, psychotherapy system in a medical school where the psychiatrist was here, the psychologist was here, and the social worker was here. Those were the only three mental health professions. And in the particular division of psychiatry where the ideas began to develop, it was child and adolescent psychiatry. And this was a time when you probably can't even imagine that this used to happen, that kids and adolescents, children and adolescents, were in the hospital for like 2, 3, 4 years. Long, long term. It's when there was really, really, really good insurance. And it was also the idea then that it took this long of treatment, this amount of treatment, to really help or be successful for a child or an adolescent. And in those days, they only had the child in the hospital, and usually after about a year or so, when they thought the child had progressed enough that they could go home, they would go home for like the weekend or sometimes even for a week. And what began to happen that they noticed was that the children and adolescents would come back from these home visits or these family visits, and they would have regressed. So there were these conflicts, sort of these dueling realities between the three major professions in terms of whose fault was it? Because at that time, the psychiatrist or the psychologist saw the child or the adolescent, and the social worker saw the mother. They didn't know that there were fathers. So, to make a long story short, they decided that what they would do is that they would coalesce as a team and have a consultant to the team, and they would invite all of the family members who could come and any professionals in the back home location who either had worked with the child or adolescent prior to hospitalization or might be working with them afterwards. Now keep in mind, for those of you who are from Texas or very familiar with Texas, that this is a state hospital, and so it's open to people all over the state. So someone could drive 11, 15, 16 hours to get here. So they decided if they were going to have people coming from those long distances, that maybe they should have like a 3-day forum. So they did. They had a 3-day forum in which the members that I mentioned to you would all come together with the 3 professionals and a consultant to the team, and they would spend the first couple of hours just talking and trying to get each person's reality. This was sort of the beginning of the introduction of the notion of reality in multiple realities, about what the problem was, what the cause was, what should be done about it, what they were hoping of the hospital and of the treatment providers. So they would spend a couple of hours with, the team would spend a couple of hours with all of these members. And then they would break into subsystems, okay? So what they call the parental or the executive subsystem, which you might have heard about in terms of structural family therapy, although structural family therapy hadn't really begun at that time. Then they would have the sibling subsystem and the professional subsystem. And one member of the 3-person team would go with each of these subsystems, and they would continue the conversations which had begun in the large meeting. And the consultant to the 3-person team would rotate and go from room to room, because this was a time before closed-circuit TV and definitely before one-way mirrors. And what the consultant began to realize is that it's sometimes, let's say, the parents and the professionals were talking about the same kind of theme or topic or wrestling with the same question. So the consultant would suggest, well, maybe you want to now switch and meet together and continue talking about this, sort of to bring in all the different perspectives. So they did 3 days of this with all of these. Gregory Bateson, I don't know if you've heard about him yet in your writings, but he visited the team early on, and he called this crisscrossing conversations, conversations that crisscrossed with each other. And so they did this for 3 days, and they were hoping that they would get a better quote-unquote diagnosis and therefore have a better quote-unquote treatment plan, and therefore treatment would be more successful. That was one of the main ideas of coming together like this, so that they wouldn't have these children and adolescents going home and regressing and then coming back and having to almost start all over again. What happened, however, for a majority of the families and the kiddies that they were working with, it was almost as if the 3 days was all they needed. And what would happen at the conclusion of the 3 days is that they would develop the treatment plan for the child or the adolescent to go back home for a trial period, say maybe 6 weeks, something like that. And the community professionals who had been there would be ready to receive the child and begin working with the child, still not thinking in terms of working with the family. When I started studying with this group at the medical school in 1970, they were still using this multiple impact therapy format. They were using it for training, and they were using it for consultations because at the state hospital, one of the things that you get are what are called revolving door cases, treatment failures, or things that you just can't imagine that you have the skills or experience to work with. So they would send them to the medical school, thinking that we knew better than they did what should be done, but not necessarily. So when I first started studying family therapy, it was in 1970, a long time ago, maybe before some of you were born. I don't know. And my psychology education had been very traditional, psychodynamic, with a couple of professors who were interested in Gestalt therapy. So I hadn't even heard of family therapy. I'd never heard of those two words put together. But one of the things that I began to notice is that people on campus were talking about family therapy with a lot of enthusiasm. And I was very curious, and so I thought, I've got to see what this is about. So I went over and I signed up for the course when it started that next fall. I had started in the summer. And it was at the first meeting that I became even more excited, and it was like I had found something that I didn't know I was looking for. I had worked at that time in the first community mental health center in Houston and also in a school district. And when I worked at the community mental health center, which was the job I had before I went to the medical school, I had been, I guess you would say, low man or low woman on the totem pole because I was new. I was the youngest. I was the least experienced of the whole team. So I had the least desirable position, at least I thought at that time, and that was a rotating position. So they had outpatient therapy, they had recreational therapy, they had a day hospital, they had inpatient wards, and they had community work where you went out to check on the patients after they had been discharged to make sure that they were taking their medication and not doing anything crazy in the neighborhood. So what began to happen, though, when that very first day in terms of the family therapy seminar, is I began to be aware of this whole idea of context and the contextual influence on not only one's behavior, but on one's perception, on one's interpretations of their experiences, and the people that we meet as well as ourselves. And I began to reflect back on my days of being this kind of rotating therapist in the community mental health center, and began to realize how I was different in terms of the way that I was, the way that I worked with and even thought about the patients in the system, depending on which particular division of the system I was working in. I also began to realize that not only did I behave differently, listen differently, talk differently, but I dressed differently. So if you were on the ward, in those days you wore a little white coat with your name embroidered on it. It made you feel very important, particularly when you're in your early 20s. And then I realized that when I went out into the community, so we're talking about like the East End, Ship Channel area of Houston, if any of you are familiar with that. It's a very impoverished area at that time and still is today, although much more, I think, probably multicultural than it was then. And I began to realize how different that was from what I was used to. But what I really noticed was that when I went to the home, let's say I was following up on a man who had been in the inpatient, the day hospital, and now he was home and he wasn't coming anymore, but he needed to take his medication. That when he came to the door, it was like I thought I had the wrong house because he looked so different than he did when I met him in the hospital. And then when I met his wife, I thought, oh, I guess he's remarried or something, or maybe this is really his girlfriend, because it wasn't the person that was written about in the hospital chart. Not at all. But it was. So these kinds of things really made me start thinking. And then, of course, I was studying with this very innovative group who were really doing some things that some people might have thought were a little bit outlandish in terms of outside the traditions of what at that time was everyday therapy and everyday or more classical family therapy as it was practiced then and in some areas still is today. So I just began seeing a lot of families and was very fortunate to have my late colleague Harry Galishan as my first supervisor, not knowing, of course, at the time how famous he was and accomplished he was and how lucky I was. I just knew that I kind of hung on to every word because it was just everything that he said was very provocative because it was so different than what I had experienced. Okay, so this was a time also when in the family therapy field, people were beginning to develop what you might think of as schools or theories or models of family therapy. And you may, for those of you in family therapy, you may know this, but I'll just give you my version of it. That family therapy began to develop from sort of two different routes. One was the route which is a medical route and a psychiatry or psychiatric route with people like Bowen and Whitaker and Ackerman and Bell and others who you have read about or will be reading about. But they were all from psychiatry or mostly psychiatry, some other areas of medicine, who began to appreciate the importance of the family in working with a patient. The other came from a more interdisciplinary, multidisciplinary perspective. So the psychiatric movement began really more so on the West Coast, and this other movement began more on the East, the psychiatric on the East Coast, New York, Philadelphia, Boston, that area, Washington, D.C. And the other direction began to develop on the West Coast. And so you had people come together and began studying communication, began studying learning, how people learn. And they came from disciplines like chemistry, anthropology, biology, psychiatry. I'm probably missing some from that particular group. So the ideas that I'm biased toward have its roots really more in sort of the West Coast thinking than the East Coast thinking, if you want to think about it geographically. This is an oversimplification, but just to kind of help create a map for you to help locate where I am on the map. So sometimes when we would have conferences, well, let's see. Okay, so in 1978, my colleagues and I, who were the family therapy team supervisors and trainers, decided to form the Galveston Family Institute, kind of as just a way to do what we wanted to do without interference, which had been the situation at the medical school until there was a new chairman of the psychiatry department who was not only not fond of family therapy, but wasn't fond of psychology either. He was very much biomedically oriented and research oriented. What began to happen was that because of the constraints at the medical school, we found our work at the Institute, like in the evenings and on the weekends, so energizing that slowly, one by one, we started matriculating over to the Institute where we had leased a space on the Strand in Galveston. Okay. So why did I stop to interject that piece? Oh, I know why. Okay, I'm envisioning this bright, I guess what color it would be, kind of teal t-shirt, and it had Third Coast on it. And we would wear those to the conferences that we began to host. And what we would do is that we would invite in people that we were really wanting to learn more about their work and meet them in person. These were people that we had read their work and were very enthused by it, but we really wanted to meet them. So we began inviting in the people from what was then the Mental Research Institute in California, people like Lynn Hoffman, et cetera, et cetera, et cetera. And so then, trying to think how to compress this for you. So when I began studying with the team, they were very interested in the ideas of communication and language. And one of the things that happened is that one of our team members, Paul Dell, you may have read or may read something of his. He contributed a lot to the family therapy literature and family process around that time. He happened to be going through a difficult divorce and decided to go to this place called the Naropa Institute in Colorado. And there he met someone called Humberto Maturana, who was a Chilean biologist, very interested in language and how we coordinate our behavior with each other in language, some of the neurological aspects of language. And so this began to pique our further interest in language. So we began reading a lot about language. And that began to take us outside of the psychotherapy and the family therapy literature into the natural sciences, the social sciences, and eventually into philosophy, where we became very interested in hermeneutics, which is the study of the text. If you think of the text as the written word or the spoken word or a person as a text. And the whole idea of how we are interpretive beings, that we're always participating, interpreting and translating ourselves, the people we meet, our experiences that we have in our lives, the events of our lives. And that these interpretations are influenced strongly by what is called our pre-understandings or our pre-experiences that we have had up until that time. So the experiences, the values, our prejudices, etc., that we bring with us to any encounter. And so that really caught our attention also. And then also combined in this along the way was a notion of observing systems, that you're always a part of what you're observing, that you can't be separate from it, and that you participate in creating your own realities. So it's like we participate in creating the people sitting in front of us. So when you're working with a client in the therapy room, whether you're working with an individual client, whether you're working with a family, a couple, or a group, that you are participating in creating the person sitting in front of you. And what I call my responses to their responses to me are part of this mutual influence of the client influencing me and my influencing the client. So the whole notion of multiple realities, the whole notion of context as a huge influence in terms of our behavior and our interpretations, the influence of what we bring with us into any encounter or any experience, are the words on the pages of a book, are things to keep in mind, and the whole notion of mutual influence, that we're continually mutually influencing each other. Another thing that began to surface for us was this whole idea, also influenced by Maturana, is that there's no such thing as instructive interaction. And so by instructive interaction, that refers to that you cannot put something into the head of another person. For example, I can stand here in kind of this privileged place this afternoon and this evening, and I can share with you some things that come to mind as I'm talking. And I think of them as I'm offering them, and they're floating around out here. And you're bringing your experiences, your biases, your learning to this point, and you're interacting with what I'm saying, and that you are creating something. So I can't influence what you are creating. And I wouldn't want to do that. And I wouldn't want to think that you would leave this room thinking the way that I do. What I hope is that you will leave this room reflecting on what you know about therapy to this point in time, whether it's individual therapy or counseling or family therapy, and what's appealing to you and why that appeals to you. Just step back and be reflective. Why does that appeal to me? Why do I like that? Why do I think I want to be this kind of therapist? What will it allow me, permit me to do, and what might it not permit or allow me to do? So that's my hope, or that's my agenda. Okay, so then one of the things that I started doing very early on was I became very interested in why would we at a medical school think we could do any better job with our clients that were referred to us, or at that time they were called patients, than the professionals out in the community, people who had lots of experience and in terms of years and in terms of kinds of practices. And because we were referred what are called treatment failures or resistant clients or revolving door clients, obviously the prior treatment hadn't worked. So I became very curious about that. And I began interviewing, or now I would say having conversations with the patients, both mine, other therapists, and then I began doing this as I began traveling around the world, asking people just to say a little bit, tell me about your experiences in therapy that helped you, and your experiences with therapists that you liked and that you wouldn't mind seeing again. And then I would say, now if you'll tell me about some of the experiences you had with therapy that you didn't think helped you at all, and with therapists who you hoped you would never see again. So I learned a lot of things. And if you get to my book in one of your classes, it's a chapter called Advice from the Experts, or something like that. But it's things that I learned from talking with clients. And one of the things that really began to surface and fit with our experiences on our team was this whole notion of the client as the expert. That the people we work with have their own strengths, their own talents, their own wisdom, regardless of the walk of life that they come from, regardless of the kind of problem, or I think of it as life challenge or life situation that they are facing. And that they really are the experts on their lives. And that it's not up to me to tell them what is wrong with them and what should be done, which direction to go. But that they need to be a partner in this. And this really fits very well, I think, with what's happening in the world today, where you have people all over the world wanting to have a voice in decisions that affect their lives. They don't want decisions made by someone up here at the top of the pyramid, imposing it on them, forcing it on them, or constraining them by it. They really do want to have a voice. And if you really take the time to listen to your clients and you become interested in what they have to say, and you believe that they have something worthy of saying and worthy of hearing, it's amazing how your job or your work as a therapist becomes not as difficult as you think it might be. So again, one of the things that we began to think about was being in a medical school. The word compliance, you hear a lot in terms of a description of a behavior or an inner characteristic of a patient, like a non-compliant patient, certainly uncooperative patient. And at first we had talked about our work as a cooperative approach, a cooperative way. And then we decided that we couldn't use that term because it had such a close relationship to compliance and non-compliance. And then I decided and suggested to the team that we use the word collaborative. Now, I looked both collaborative and cooperative up in multiple dictionaries, and they have almost precisely the same definitions, but it's the influence of context, the context of therapy practice, that cooperating with in the sense of, quote unquote, making the doctor happy, or collaborating with in the sense of two or more people doing something together. I often think of it as like wrinkling our brows and putting our heads together, thinking together, talking together, or like you take a walk with someone. It's something that you do alongside them rather than leading them in a particular direction by pulling in front or having a carrot or sort of nudging from behind. So we began reading also in terms of dialogue and theories of dialogue. We became very interested in social construction theory and then postmodern philosophy. And currently I use the term postmodern philosophy as kind of an umbrella term under which I put a lot of similar concepts that I see as having as being threads that run through these various perspectives of hermeneutics, dialogue theory, social construction theories. And so let me just highlight 3 things, okay, that I put under this umbrella that I call orienting assumptions. And, and by the way, I did bring some, what did I do with them? I did bring some handouts, so you don't have to write this down. I'll just talk about the 3. There's 7 on here. If you don't mind helping me. Okay, thanks. Okay, so on here I call them perspective orienting assumptions. In other words, assumptions that orient your perspective, that begin to influence and inform your perspective. And the first one I call maintaining skepticism. So, from a postmodern perspective and from a social construction perspective, excuse me, knowledge is thought of as a communal process. It's something that we do together. And there's a lot of skepticism about sort of pyramid-type knowledge, where the knowledge is created up here, usually in what's called the academy, and sort of filtered down to the rest of us in the profession and out into the general public. So maintaining skepticism means that you always take a critical, a questioning, a skeptical perspective regarding what one might think of as inherited, taken for granted, and often invisible knowledge. So like I was saying a moment ago, that if a particular theory of psychotherapy or family therapy appeals to you, step back, be reflective, and think carefully about how come that does appeal to you. What are the implications? What are the what would you say? What freedom or creativity does it allow you, or how does it constrain you? So another way of saying it is very simply, you hear this all the time, be an informed consumer. Okay? Just think about some of the things that you've learned in psychology and in marriage and family therapy and in your introduction to counseling that have been passed down from generations and generations of therapists, one to the other, that have become almost like sort of the Bible of most approaches to psychotherapy, or at least some of the concepts. Okay, so think of things like self-disclosure, think of things like boundaries, and where did those come from? And when were they developed? And what relevance do they have for our lives today, particularly in the Western world, as well as other parts of the world for sure. So again, it's be questioning, be critical, not in a negative sense, but in a thoughtful, careful, analytic sense. The second number on there has avoid generalizations. That when you work from these broad bodies of knowledge that you've taken on as the truths, sort of as the points in your Bible, and I don't mean that in a pejorative sense, but I guess you could say the points in your rule book, your therapy rule book, that it's very easy to begin to generalize people and place them into categories. Think of them as kinds or types of people, or think of their particular life circumstances as a kind or type of problem. And what happens when you begin to do that, and I'm also including things like diagnostic labels, categories, informal diagnosis that we have of the people that we work with, like in denial or resistant behavior, etc., that what happens is that you really miss seeing sort of the nuances or the novelty or the freshness of that particular person, because you begin to see them as if you've met them before, or you've met their life circumstance or challenge, usually called a problem or diagnosis, before. So when you think you've met something before and you already have your own description, your own map of it, often that's what you find. In other words, you tend to validate your pre-understanding, your generalization that you bring in the room. And what I have found in my work over the years is that it's these differences between people, no matter how much they look alike, or no matter how much this mother's story sounds like this mother's story, that they're not alike. They're different. And it's like, how can you learn about the differences? And one of the ways to do that is by always keeping in mind or having the perspective, if you can, that the client is the expert on his or her own life, and how to be curious about their life, and how to be curious about what they're telling you. Not to have a recipe or a map of questions that you bring into the room with you, and these are the questions that you have to ask in this particular order. But to let the story lead you. Now, sometimes people say, well, how can you trust that the client or the patient will tell you what you need to know, or they'll talk about what's important, because some people are in denial, or some people are hesitant to really tell you. And I say, well, I trust that whomever I'm working with will begin where they want to begin, where it feels safe and comfortable for them to begin, and they will begin to tell me what at that time they think is important for me to know and that they want me to understand. And that I find that works. I don't have to lead the conversation in terms of selecting the topic or the avenue or the path that we will go down. Now, okay, so then techniques, okay. So provocatively, I'll say I don't think in terms of techniques, because I think that the orienting perspectives inform what I call action guiding assumptions, or what I also call a philosophical stance. In other words, it's a stance, it's a position that I take regarding the way that I think about myself, the people that I work with, and what we do together. And important in this is the whole notion of the idea and the word with. Being with, doing with, relating with, talking with, thinking with another person. And that's in contrast, and again I exaggerate to make a point, in talking to, for, at, or about another person. So what begins to happen is that you do begin to have a more egalitarian, a more horizontal therapy system, and a less hierarchical, dualistic one, because you're really thinking of yourself and inviting the client to be in there together with you. But the students who come to the Houston Galveston Institute to do their internships and their practicums, and we certainly enjoy having those of you from Sam Houston come. I think we have, what, one or two this year? One. Yeah, just started. Okay, yeah. So often they say, well, okay, so we want to learn about collaborative practice, or now I call it collaborative dialogue. How do we do it? What do we do? What are the techniques? What questions do I need to ask? And what I used to do when I was more involved in the day-to-day training of the Institute, I would be very mischievous in a way, and I would say, okay, now there's a family coming in at 2 o'clock, and this will be your first family, and I want the two of you to go in there, okay, and meet with this family. Now I want you to listen very carefully to my instructions, okay? Instruction number 1 is I do not want you to go in there and try to do therapy, okay? It's forbidden. Instruction number 2 is that I want you to go in there and I want you to sit down and I want you just to talk with them and learn about them and let them know a little bit about yourself, okay? Those are your only 2 instructions. Those are the only 2 rules. Okay, because what I have found in my years of practice and years of working with new therapists is that you develop this idea about how you think you should be as a therapist in the room, what questions you should ask, how you should cross or not cross your legs. You develop all of these ideas, and they become very constraining because you can't think. And most importantly, you can't be present. In other words, you lose all of those social skills that you have. you know how to sit next to someone new in class and turn and start chatting and find out where they're from, et cetera, et cetera, et cetera. Or you sit on an airplane and you talk to the person next to you. Or you're at some kind of social or meeting at a church and you begin to meet people. You all know how to do that. Some of you are more comfortable. Some of you may be less uncomfortable in those kinds of situations. But I want the new therapist at the Institute to learn to be comfortable and to think of themselves as simply a human being with another human being or with several other human beings. Okay? It makes a big difference. The other thing, I don't know if this happened on the team that you were on with me, Adriana, but I think seating arrangements is important and influences how people can talk with each other. So notice, like, if you have a big family sitting right here and the therapist is sitting here in sort of the big mother chair, how can you have a conversation? You can't even see each other. So I prefer to be in a seating arrangement that's a circle as much as possible, and to have each person, including myself, in the same kind of chair, so that there's not a special chair for the therapist. Sorry, I told you, these are my prejudices and these are my biases. So sometimes on my team, they would joke with me, and one night a team member came in with a yardstick and sitting there with a yardstick on her lap, and I thought, I can't resist. The yardstick, you did get my attention, I must ask. They said, oh, well, you like, what is it called, an equilateral triangle? In other words, I say if there are two therapists and one client, or one therapist and two clients, or three clients, that I want them in a circle with about the same amount of distance between them. So they were going to measure the distance between the chairs. So anyway, that's just a diversion. Okay, so back to how do you do it? What do you do? Well, I've developed two metaphors that I use, okay, in my writing and in my talking and in my trainings. And one is what I call the host-guest metaphor. And it's really very simple if you can wrap your mind around it. That I suggest to the new learners, the new therapists, that they always consider themselves both a host and a guest in their client's life. That as the therapist, they are hosting the client, the family, in their space, their physical space and their metaphorical space. And at the same time, they are a guest in the client's life. And I have them do a little exercise. I say, I want you just to pair up, and I want you to share with each other some experiences you've had as a guest in someone's home or classroom or office. And what did the host do to make you feel welcome or not, special or not, and most importantly, that they might invite you back again. And then I say, likewise, I want you to think of yourself as a host. And you were hosting someone in your classroom, in your church meeting, in your school, neighborhood center. And think about the guests who were there. What did they do that made you want to invite them back? They probably weren't intrusive guests, okay? They probably didn't go in your kitchen and help themselves to your fresh orange juice without asking. They probably didn't just go in and use your restroom and start looking through your medicine cabinet to see what you had in there. They probably weren't intrusive. So keep in mind, you don't want to be an intrusive guest in your client's life, okay? This has to do with the idea of the therapist assuming or thinking that they have more or better expertise than the client does. That you think you know better than they do. But anyway, a host guest. And basically, one time I was in Japan and I was on a panel with some psychologists and psychiatrists, and the psychiatrist sitting next to me turned to me and he said, okay, so the host guest, what is the point? And I said, the point is very simple. have good manners. That's all I'm really saying. Think of yourself as a host or a guest who has good manners. Okay. The second metaphor is what I call the story ball metaphor. 2 words, story ball metaphor. So, of course, you're wondering, what in the world is that? Well, I think that clients come and bring us a very precious gift. And I think of that gift as a story ball that's been made up of all the narrative fragments of his or her own life up until that point. Another way of thinking about it is as if their life is a novel up until the current time, and that unfortunately that novel has gone through a paper shredder, very popular these days to put everything through paper shredders, but somehow it went through a paper shredder, and just before they came in, they reached down on the floor and they sort of scooped up all these shreds of paper, and they began to form them and make them into this ball, okay? Now, imagine if I had brought that kind of ball in the room. I do have an overhead that I didn't bring, that I have 2 different versions of this on there. So if I had this ball and I was the client and you're the therapist, and I'm coming in and I'm handing this ball to you, showing this ball to you, what do you see? It's not opaque or transparent. You can't see through it. You can't see the whole circumference. You can only see that part of it that I'm putting in front of you. And it's not smooth. It has all these little pieces of paper sticking out with words on it, and they're different colors, and et cetera, and et cetera, et cetera, and have some things that don't even look like words on it. So I say to the new learners, I say, okay, so think that the client is bringing you a very special gift. Now, what I want you to do is I want you to look, I want you to gaze upon the ball. You may reach out and gently touch it, but I don't want you to take it away from the client, okay? Because as therapists, and I was certainly trained this way early on, we're trained to go into the therapy room with our therapist map. I guess you could think of it kind of like a Ouija board. And you take this ball from the client, you take their story, and you roll it around on there. And your map tells you what's wrong with the story, what the correct or more useful story should be, and it tells you the strategies and techniques for rolling the ball in that direction. So if you're thinking about trying to work collaboratively with a client, that one of the things that you want to think about is how can we design the therapy together. Now, I'm sure this will just freak you out to hear that your client is a co-designer of the therapy. But that's the way that I think about it. So when they're showing you this story ball, which you're not taking from them, but you can touch, you can look at it, you can be curious about something you think you see over here or something you think you see over here or down here. However, what I suggest is that you try to stay as close to the story that they're telling you as possible. And they will tell you what questions to ask. You know, it's just like you're reading a really interesting book and you can't wait to turn the page and find out what happens next. You're wondering about this, you're wondering about that. It's not something you wondered about before you started reading the book, but it's something that the book, the story that you're reading is telling you to be interested or curious about. That's the, if you want to call it the skill or the art of a really excellent author. What's coming next? So my colleague Harry Galish and I began to say, when people said, well, what kind of questions do you ask? How do you know what to ask? We would say, we ask conversational questions, questions that are informed by the conversation itself. They're not preformed questions. We don't have anything that we're supposed to fill out in terms of gathering particular kinds of information. And I'll detour in a minute and give you an example of how, if you're in a setting where that's required, you can do that. And so let's say that I'm talking with a couple, and they come in, and there's been some indiscretion in the relationship. And the words forgive and forgiving and forgetting keep coming up, and they can't get past this. Either neither nor both can forgive or forget, or one or the other. And let's say that while I'm listening to them talk about this, I remember a couple of months ago that I read an article in a journal, and it happened to be research on couples who were having trouble forgiving and forgetting some indiscretion or traumatic event in their relationship. So I'll wait for a natural pause in the conversation, and I'll say, as we're talking, I'm remembering something that I read about research with couples struggling with something similar to what you're struggling with. Not exactly the same thing, but something similar. And if you're interested, I can tell you about it, but you just let me know. If you're not interested, that's fine. So what I do is I wait for a pause. I let them know what I want to share with them. I do it in a way that it's offered as what I call food for thought and dialogue. It's not that I'm going to tell you about this research and this is going to give us the clue or the answer to what we're struggling with. And I ask them, does this interest you? Do you want to hear about it? And people sometimes respond directly, oh, sure, yeah, we need all the help we can get. Or, no, we don't, or one of them might say, I don't believe in research. And the other one said, well, yeah, I want to hear it. And I'll say, well, okay, so since we're not all on the same page, let's just put that on the table over here, and maybe we can come back to it later. So I pay very careful attention to, again, what I call their responses to my responses to them. I'm not making any kind of judgment that they're in denial, or they're resisting, or they're not interested in what I want to hear, because I'm not offering it as something that they need to do or they need to think about. I'm offering it as a possibility of a way to talk about something that to that point we haven't found the most successful way to talk about, or to talk about something which they have had trouble finding ways to talk about at all. So that is the way that collaborative therapy goes. You have a curious therapist who thinks the client is the expert, and you try to learn from them. In this process of the learning, you're participating in their storytelling. So you, of course, are influencing the story to be told, and they are influencing how you hear and how you listen to it, as well as what you bring in with you. So as people begin in this process of storytelling with the therapist's curiosity, whether you're offering comments or asking questions, or shrugging your shoulders, or rolling your eyes, or raising your eyebrows, whatever you're doing, or reaching over and touching someone's arm, that you're participating in their storytelling, in the clarification of the story, in the editing of the story, and in the creating of slightly different versions of the story, are helping to solidify whatever particular version that they want to highlight that they find most useful. So it's the idea of being in conversations that are dialogical, that are inherently generative and transforming, that there's a movement to them. Things continue to move along and develop, and newness begins to come. Now, one of the things that often happens for therapists, regardless of what kind of therapist you are, is that it's very easy for us not to be so modest in terms of our expectations of ourselves as therapists and of our clients. So I also suggest to new learners to be modest in what you expect of yourself and what you expect of your clients or your patients or your customers or your consumers, whatever the organization you're working in calls or refers to the people that you work with. I think when you think modestly, you're much likely to have smaller successes, and I do believe in my experience that small successes accumulate and become useful successes, or maybe you can think of as big successes. The other thing that I tell new learners is, in terms of modesty, is to keep in mind, and this goes back to the generalization, when you think you know someone, you think you've already heard their story, and you know exactly from your books and your experience, this is where they need to go to sort of be free from whatever the prisoning chains are. Second, the thought just go away. I'll come back in just a second. Just went somewhere. What was I going to say? Okay. Well, I was talking about dialogue as a generative process. So the whole notion of collaboration, the whole notion of dialogue is inviting someone to do something with you. And there are many ways in which you do that. There are many ways in which you position yourself so that you're not the expert with all the answers. Now, sometimes people say, oh, but, sometimes clients do come in and say, tell me what to do. Or they'll give you a long story about their 10-year-old little boy who won't go to school. Now, if this were your son, what would you do? And we're tempted to feel on the spot and that we need to answer. Well, clients do ask that sometimes. And if when they ask me that, and at that point in the conversation I have some ideas, I might say, well, as we've been sitting here talking, I've had probably 3 or 4 different thoughts about that. And I can share those with you if you want. So what I'll do is I'll share spontaneously some ideas. Again, sharing 3 or 4, not one, because I don't want them to think this is the thing to do. But what I want to do is I want to share my thoughts, my ideas about the predicament, the situation, and some things that might work, or from other clients that I've met with, that this is something we can talk about. And we can see, is there something here that might be useful to you and your family, or you in your concerns with your little boy? Or that we can take something from it and fine-tune it to your situation. So in other words, I'm always inviting them. I'm not saying, well, no, this therapy's for you, not for me. Or I'm not saying that, well, I can't give you the answers. It's really better if you get your own answer. So things like that are rude, I think. They're not having good manners. So I always want someone to think that whatever we're doing, we're working towards something, but we're doing it together. So stumbling blocks, I think, in any therapy, in addition to being a collaborative therapist, is when you're not modest, when you really think you know better how another person should live his or her life, when you're working in situations where you have on both a therapy or counseling hat and a social control hat, which in some agencies and some organizations you'll be wearing both hats, and you need to be clear about which hat you're wearing at any one time, and you need to let your client know which hat you have on. Okay? Because sometimes when you receive referrals from, say, like Child Protective Services or juvenile court, clients often think of you as just one more professional, but you're kind of the one with the atomic bomb rather than a fly swatter. Connected to that is the idea that the people we work with have ideas about us before they ever meet us. And so you want to keep that in mind, and keep in mind where those ideas come from. We have, as psychotherapy professions, trickled those out into the broader cultural discourses. They come from media, they come from the Oprah show, or Dr. Phil, or they come from movies like, what is it, what's the movie about Bob, Where's Bob, or something. But people, or they talk to someone who's been to therapy, but people have these ideas about what therapy is and what a therapist is like and what you're supposed to be doing. So keep that in mind. They've already got you on a pedestal, someone who knows all of the answers. Also keep in mind that if the people you work with, and this is more the case these days than it used to be some time ago, that a lot of people have been to multiple kinds of therapies already. So you're sitting there and you're like the ghost of all these prior therapists, all combined into one. So you want people to know you as who you are. People come to me and they don't know who Harlene is or Harlene Anderson is. So I want to have some influence over how, or some, what would you call it, choice. I have a lot of choice over how I present myself, how I meet and greet another person, and how I position myself with them from the very beginning. So those are some of the stumbling blocks that come to mind right now. There might be some others. Collaborative and narrative, let me just say something about that, and then I'm going to pause and give you some time to talk, because I've been talking for quite a while, it seems. Okay, keep in mind that any, whether you call it approach, school, therapy position, comes from a particular context. It comes from the context in which the people who developed it have practiced and worked. It's also influenced by their own personal life context. It's influenced by geographical, political, social, economic context as well. So if you think of collaborative and narrative, and if you think of narrative therapy as having been developed by two social worker men, one in New Zealand and one in Australia, and at the time that it was being developed, that they brought to it their own particularly professional and personal interest, which happened to be sort of an anthropological interest and interest in stories and narratives, and a political change interest over here on the Australian side. And that this was also at a time when in New Zealand, and particularly in Australia, there was a big movement. It was the beginning of the big movement to restore justice, so to speak, to those people from whom justice had been taken away from, talking about the indigenous people in those two countries and how their land had been taken away from them. People were trying to take their language away from them, their educational philosophies, and the ways they organized their schools and their lives. So these kinds of things influence it, as well as the wife of one of the men was very involved in the feminist family therapy movement. And so her feminist ideas are in there as well. On a collaborative perspective, we worked beginning in a psychiatric hospital where we worked with very challenging clients who failed, and always trying to find a way to not fail, or maybe not fail as badly as our predecessors had. And became very interested in, again, the client's expertise on his or her life, and particularly in terms of therapy that worked and didn't work. So they're different origins. Harry Galishan, that I mentioned earlier, was very influential as sort of the core faculty member in the family therapy movement at the medical school. And he had a Jesuit education in the Catholic school, which is sort of very, very focused on a lot of philosophy, studying a broad variety of literature. And he was very inquisitive, very challenging of ideas, and very irreverent to a lot of dominant discourses, as the two men in the beginning of the narrative movement were. Now, both are influenced by some of the same ideas that come from philosophy, ideas around language in particular, and the construction of reality. But the narrative has much more of, or I wouldn't say it has much more, it has a political agenda. Again, to oversimplify, is that a narrative therapist sees problems as being influenced by the dominant discourse, and people being subjugated to, or prisoners of, are unduly influenced by dominant discourses. So the idea is to, again, I'm exaggerating to make a point because we're doing this so quickly, rescue them from these dominant discourses and help these, what are the under discourses called? Come forward in their lives, storylines, some other storylines to come forward. So they would have that particular outcome agenda. And my agenda as a collaborative therapist is simply to have a process that's generative and to trust that we will get where it is that we want to be at the end, that we can have an idea about where we want to go, nothing wrong with that, but to keep in mind that through conversation, through relationships, where you want to go changes, or certainly can change over time. Okay, so I'm just going to pause now because I've been talking and talking very rapidly, I realize. So just now turn and talk with each other and see where you are in terms of your original thoughts, your original question or comment, whether you voiced it out loud or not. And I'll respond to what you have to offer. You do. And then back to where? I thought you lived out this way, yeah.
But I have a student, teaching intern I have to observe.
Okay.
So it was so
Well,
great
very
to
nice to
hear
see you. Yes, thank you. My hands are kind of cold, but yeah. Thanks for bringing some of your class. And I look forward to seeing you again, hopefully sooner rather than later this time. Have a good evening.
Come to some workshops or something going
Yeah.
on at HGI.
Yeah, well, all of you who are supervisors, I didn't realize that my
Oh, I didn't notice.
top was rolling up because of this thing.
All of us.
Don't want my stomach on me. Oh my gosh.
I never noticed it, so your jacket.
I turned it off when I was talking about how my shirt had hiked up. Certainly philosophers like Wittgenstein, Bakhtin, Merleau-Ponty, Rorty, writing in the area of language primarily. Okay. Other questions or comments? Yes.
More about the social versus the therapy.
Okay.
In general, more side the social role side. I guess if you have what I would describe as a dual relation or dual function within a business, I just really didn't grasp what you meant by that.
Oh, okay. That sometimes we work in an organization or an agency where we're hired to work as a counselor or a therapist. And we think that's what we're going to do. But that agency may also have what I call a social control or social responsibility in terms of they receive clients like from Children's Protective Services, adult probation, juvenile institutes, a variety of places that have some connection with, I'll say, the law or some kind of legal rules and regulations. So you have these two expectations placed upon you as the counselor. One is to be helpful in your counseling role, and the other one has to do with normalcy or what's normal within the particular culture that you're living in. Now, one of the things that can happen, I just came from a conference in Norway, and there was a psychiatrist who gave a talk called The McDonaldization of Childhood. And he was talking about how all of these things interfere with children and with childhood, and how as professionals we can easily get diverted in our roles, or in terms of these two hats, wear one more than the other. So, for example, and this is not a critique of the Child Protective Service or child welfare system, it's just something I want to say, that it's very easy to think of yourself as the advocate for the child, protecting the child. In other words, being aligned with, being on the child's side, and losing perspective of the other people in a child's life, whether those other people happen to be parents or grandparents or a next-door neighbor or a teacher or a coach. It's very easy to lose sight of that broader context in which the child lives, and how important it is, from my bias and my experience, to have the adults in a child's life working on the same team for the betterment of the child. Or let's say that you're supposed to investigate a family, and that your investigation yields that you think the mother's boyfriend should not be living in the home. However, he's the financial support of the mother and the children. So I'm not saying that he should live in the home, but I think there are just so many things to keep in mind, and you don't want to get swayed on one side versus the other, getting people in or out of homes. Does that help?
Very much.
Okay. So it's a hard position to be in.
And how that, it's a natural. Talking about giving suggestions. If you get a really why
Okay.
they ask for your
It's connected to this question in a way, because then we're also not only bringing in the broader cultural values, but we're bringing in our own values, our own biases, our own morals. One of the things that I find is that if you can engage people in working with them and them with you from the very beginning, and this is influenced in so many subtle ways, as I mentioned, one, good manners. I will say, I don't find this happening, okay? Because one of the things that happens is that when I talk about bringing in our map, this is our sense-making map, our logic map. And so what we often do is we're trying to roll the client's story ball on our map, our sense-making map, trying to make sense of it from our perspective. And often it doesn't make sense if it's something that's very foreign to you, doesn't fit with your values, or you're worried about this or you're worried about that. You are not in a position to be able to be curious about the other person and try to understand something from their logic or their sense-making map. Once you understand something from another person's sense-making or logic map, you're in a very different position. Now, by understanding, I don't mean that you're agreeing with it or you're supporting it or condoning it, but it makes sense. This is what he's trying to accomplish in hitting his kid or beating his wife. This is what he's trying to accomplish. And this gives us something to talk about, whether it's his frustration or whatever it might be. That's also what I'm referring to when I say the clients tell you what questions to ask, so that you're not putting them in or putting yourself in an adversarial position. Does that help, or you have a follow-up question?
No, that helps.
Yeah.
I was just thinking if
Well, also to back up a little, it has to do with a relationship. Relationship. You always want to try to be building a collaborative relationship, a good relationship with the clients you're working with, so that you're inviting them to engage with you, and that they feel like it's their therapy, not your therapy, that you're placing them in. It also, when I talk about the idea of the story ball and inviting someone into mutual or shared inquiry is what I call the process. Just floated away again. I'll attribute it to jet lag. I just got off a plane last night from Norway, so a little foggy by this time. So anyway, it'll come back. But the relationship is so important. You want to have, I know what I was going to say, a therapy in which people feel that they're participating, and when you feel like you're participating in something, you feel like you belong. You begin to develop a sense of ownership. This is mine. This is my therapy. You're contributing, and when you contribute to whatever, if you want to call it the outcome, the goal, the resolution, the product is, it's going to be more sustainable because it's something you've participated in creating. So it has to do with, it all starts from the very beginning, which is really before you even meet the client. Again, in terms of their ideas of you, the reputation that you as a representative of your particular agency has for them in the community, or whatever the referral sources told them about you. Okay, other questions or comments at this time? Okay.
The underlying theme.
Mm-hmm.
I thought that really.
Okay, thank you, because I didn't say that yet. It's really non-judgmental, non-blaming, respectful. Which, interestingly enough, there's probably not a therapist that you would ask, are you judgmental or blaming? No. Are you respectful? Yes. But I think that sometimes we can do things unwittingly, out of a good intent, particularly when you believe in confrontation. You've got to confront this person to really accept that this is the reality of the situation. It's not a way of engaging the person to work with you. So if you think about it, when you're working alongside someone and they're sharing the work with you, it's, as I said in the very beginning, it makes your job a lot less difficult, a lot more fun, I think. And you'll be amazed at how creative and imaginative your clients can be and how they can come up with things that you would have never thought of. Also, maybe in trying to pull all this together is to keep in mind that a lot of therapy doesn't happen in the therapy room. It happens outside the therapy room. As people take those conversations you've had with them, ones that they're having with themselves, that they begin to have with other people, ways that they begin to think or act. And so the newness or the difference doesn't necessarily occur in the therapy room. Again, if you think modestly, the therapy room is an artificial environment. You have this very important, very delicate, some people say sacred conversation from 9 a.m. to 9:50 a.m. on Tuesday mornings in this little office. It's not part of people's everyday life. So it's important to keep in mind that we're not as important as we sometimes think we are in another person's life. So thank you so much for inviting me.
Thank you. And I just want to know of more training or places that students can come to learn more and to maybe have some more instruction from you. Do you know of, is there a website you would direct us to?
Well, the
Maybe HGS
Houston
website?
Galveston Institute website. I have a website. Can form something special like I've had students from other universities come in groups of like 10 or 12, and I had one group from St. Mary's University come, and they came for 8 months, once a month, spent the whole day.
Wow.
12 students. They rented a gigantic van, drove down together. So there are many, many ways that you can do it, either in terms of trying to fit into something that's ongoing or creating something special, and just keep in touch with Adriana. And I don't know if you know Kathy King. She's also a member of the Houston Galveston Institute. And yeah, who else is out here now? Oh yeah, Victoria Lou. Yeah.
And Gina was Mark Girardi was a master.
Oh yeah, Mark. Yeah.
Is he's not there? He's still there. He's there.
Yeah, he's
working on his license.
Judy, I counted up about 6 people that.
Oh yeah.
Kyle is our most recent one, but I am so grateful to you for taking time out of your busy
My
schedule.
pleasure. My
because
pleasure.
I have wanted her to come. I've been here 17 years, and I've wanted her to come 17 years, and we can't let you leave without giving you something from
Oh my
Sam
gosh.
Houston.
Oh
So
wow, from
here
Sam
is
Houston.
a paperweight
Oh, how
for
wonderful. Oh my gosh.
you from Sam Houston,
This is, oh wow.
and
Have you seen these?
of course, we can't let you go without having something to drink.
A Go Cup.
See the Bearcat paws there. So just to say thank you
Well,
coming
thank
and
you. Oh my
sharing so much
gosh.
with us. We appreciate it.
Let me give you a hug.
oh,
Thank you.
absolutely. When I think
Heavens.
when I hear you, I just think of Sally Helms. Just
Yeah, Sally Helms.
wasn't she amazing?
Amazing.
This was over there. Yeah, she was such a strong.
Her dissertation would be a course.
It's just
It's 700 and something pages,
yes.
and she was phenomenal.
Yes.
But unfortunately, she's no longer with us.
It was a bricolage, and I
Yeah, Bricolage, yeah.
heard of that. So I was her student.